Good day, class. Welcome to today's lecture. I am your instructor, and it is my privilege to guide you through a topic of immense clinical relevance in our region, the pathophysiology of malaria. When we analyze this disease, we must look beyond the fever and understand the microscopic warfare occurring within the host. While we recognize various Plasmodium species, it is Plasmodium falciparum that demands our utmost respect due to the severe pathology it produces. Note that the clinical signs we observe are primarily driven by the asexual erythrocytic stage of the parasite. Today, we will unravel the mechanisms at play, specifically the destruction of red blood cells, the phenomenon of cytoadherence, where cells stick to vessel walls, and the double-edged sword of the host immune response. Let us proceed.
Moving deeper into the pathophysiology, we must examine the destruction of the red blood cells themselves. It is a brutal process, I tell you. First, we have the direct lysis. As the parasite matures, the schizont ruptures, shattering the erythrocyte to release new merozoites and toxic hemozoin into the bloodstream. But the destruction does not end there, no. The spleen, in its duty to filter the blood, becomes hyperactive. It engages in pitting, removing parasites from cells, but in doing so, it destroys not only the infected cells, but also many innocent, uninfected erythrocytes. To make matters worse, the body cannot simply replace these lost soldiers. The malaria toxin suppresses the bone marrow, causing dyserythropoiesis. So you have rapid destruction on one hand and a paralyzed production line on the other. This is the mechanism of severe anemia.
Furthermore, let us look closely at the deceptive mechanism of cytoadherence. The Plasmodium falciparum parasite is quite cunning. It remodels the surface of the infected red blood cell, creating sticky protrusions called knobs, mediated by the PFEMP1 protein. These knobs act like Velcro, binding firmly to receptors such as ICAM1 on the endothelial walls of your blood vessels. You see, this is not accidental. By sequestering in the deep vascular beds, the parasite avoids circulation through the spleen, which is the body's primary filter for destroying abnormal cells. But consider the consequence. As these infected cells accumulate and stick to the vessel walls, they create a blockage. This microvascular obstruction prevents fresh blood from reaching the tissues, leading to local hypoxia. The organs begin to starve of oxygen, resulting in the severe dysfunction we observe in clinical cases.
Moving on to the immunological warfare taking place within the host. When those schizonts rupture, they do not just release merozoites, they release toxic waste products, specifically glycosyl phosphatidyl inositol, or GPI anchors. Now, the body does not take this lightly. These toxins violently stimulate our macrophages and monocytes, waking them up to fight. Consequently, we see a massive release of pro-inflammatory cytokines, specifically tumor necrosis factor alpha, interleukin-1, and interleukin-6. This is the biological mechanism behind those violent shivering and fever paroxysms your patients present with. But be warned, excessive inflammation is a double-edged sword. It leads to endothelial activation and capillary leakage. If this cascade goes unchecked, the patient spirals into shock. It is not just the parasite harming the host, it is the host's own overwhelming reaction to the invader that often causes the most severe damage.
As we draw the curtains on the pathophysiology of malaria, let us cement these critical complications in your mind. When the parasite sequesters within the microvasculature of the brain, triggering a cytokine storm, we witness the deadly cerebral malaria, manifesting as coma and dangerously high intracranial pressure. Simultaneously, consider the kidneys. The massive destruction of red blood cells leads to hemoglobinuria, famously known as blackwater fever, which precipitates acute tubular necrosis and eventual renal failure. Furthermore, The systemic tissue hypoxia forces the body into anaerobic glycolysis, causing a lethal accumulation of lactate and metabolic acidosis. These are not merely academic terms. They are the physiological battles occurring within the patient. You must understand these mechanisms deeply to save lives. Study these pathways rigorously. I wish you all the very best and outstanding success in your examinations.